Hi, good morning everyone. So today we'll be talking about anatomy of prostate and benign prostatic hyperplasia. BPH itself is a 10 marker for you people. Anatomy of prostate may come for 5 markers. So what is a prostate? It is an accessory gland of male reproductive system. It is composed of glandular tissue embedded in fibromuscular stroma. It surrounds the first 3 centimeters of your urethra. So embryology, it is from the primitive urethra, a series of solid epithelial buds develop and become canalized in a matter of weeks. The surrounding mesenchyma forms the muscular and connective tissue of the gland and has a major role in differentiation, that is the stromal epithelium interactions. Skin tubule, which opens on either side of the female urethra, and the homologue of the prostate. So this is the anatomy of sagittal section of the anatomy of prostate, where you can see the bladder and below that is your prostate gland. You can see the urethra, that is the first 3 centimeters of your urethra is covered in prostate. So it comprises of 5 lobes, that is anterior, posterior, 2 lateral and 1 middle or median lobe. Primary carcinoma is said to begin in the posterior lobe. Middle lobe produces an elevation in the lower part of the trigone of the bladder. Adenoma is more common here due to more amount of glandular tissue in the middle lobe. So capsules, there are 2 capsules, that is true capsule and false capsule. True capsule is formed by the condensation of peripheral part of the gland itself, and it continues with the stroma of the gland. Whereas a false capsule, it is derived from the pelvic fascia. On each side, prostatic venous plexus are embedded in it. So it lies outside the true capsule. Between the anatomical capsule and the prostatic sheath lies a prostatic venous plexus. So this is showing the lobes of the prostate and the venous plexus. So there are again 3 zones, that is lobes, this is zones. There are 3 zones: peripheral zone, periurethral transition zone and central zone. So what is peripheral zone? It lies mainly posteriorly and from which most carcinoma arises. What is transition zone? Transition zone is where the BPH arises, and central zone, it lies posterior to the urethral lumen and above the ejaculatory ducts as they pass through the prostate. The 2 zones are rather like an egg in an egg cup. Smooth muscle cells are found throughout the prostate, but in the upper part of the prostate and the bladder neck, there is a separate sphincter muscle that subserves for the sexual function, closing during the ejaculation. So resection of this tissue during the prostatectomy process, that is what is responsible for retrograde ejaculation. See, they can ask you what are the they can ask you the adverse effects of prostatectomy, and retrograde ejaculation is a must, you have to tell. This is again the sagittal view of the prostate, the same thing which I showed you before. Blood supply. Okay, the blood supply of the prostate, it it is supplied by branches from the inferior vesical artery, middle rectal and internal pudendal artery. The veins form a rich plexus around the sides and base of the gland, and these plexus communicate with the vesical plexus and internal pudendal vein, and then it will enter the internal iliac vein. Coming to BPH or benign prostatic hyperplasia. What is the etiology? Etiology is hormones. Some testosterone, serum testosterone levels slowly but significantly it will decrease during the advancement of your age. Levels of estrogenic steroids are not decreased equally. When compared to testosterone and estrogen, testosterone will decrease according to age, but estrogen will remain the same. According to this theory, the prostate enlarges because of increased estrogenic effect. It is likely that the secretion of intermediate peptide growth factors plays an important role in the development of BPH. Another thing is hypothalamus pulsatile release of LHRH, that is luteinizing hormone releasing hormone of LH from anterior pituitary stimulates Leydig cells of the testes releases testosterone. This reaches the prostate, releases SA reductase type 2 of the prostate. This converts testosterone to dihydrotestosterone for its effect. So now what will happen? Dihydrotestosterone is 5 times more potent than testosterone. So 90% of this testosterone is from testis. Remaining 10% is from 10% of the testosterone is from the adrenal cortex. This is how this is the advancement of BPH. Pathology. BPH affects both glandular epithelium and connective tissue stroma to variable degrees. These changes are adenosis, epitheliosis, and stromal proliferation are seen in differing propositions. BPH typically affects the submucosal group of glands in the transitional zone, forming a nodular enlargement. Eventually, this overgrowth compresses the PZ glands into a false capsule and causes the appearance of a typical lateral lobes. When BPH affects the subcervical CZ glands, that is central zone glands, a middle lobe develops that projects up into the bladder within the internal sphincter. This is here, as you can see, from the central zone, it is going into the bladder. This is how it advances. So, enlarged prostate, it compresses the prostatic venous plexus, causing congestion called as vesical piles, leading to hematuria. This is showing the enlargement of the median lobe of the prostate, which is going into the urinary bladder, which will cause compression and hematuria. So clinical features. Frequency occurs due to introversion of sensitive urethral mucosa into the bladder. So due to cystitis and urethritis, there will be frequency, urgency, hesitancy, nocturia, overflow and terminal dribbling. Pain in the suprapubic region and in the loin due to cystitis and hydronephrosis. Acute retention of urine, chronic retention of urine also can occur in BPH. Retention with overflow, high pressure chronic retention with functional obstruction can happen. Impaired bladder emptying with its problems like cystitis, urethritis, stone formation and residual urine. Hematuria, as I told you before, then this is not necessary for you. Okay, hematuria and then prostatism is a combination of symptoms like frequency both at day and night. Usually in BPH there will be frequency in the night, but here both day and night can occur, and there will be poor stream of urine and delay in starting the maturation. Features of urinary infections like fever, chills and burning maturation will be present. This is showing the different phases, that is obstructed outflow and reduced stream. So what are the signs? Tenderness in the suprapubic region with palpable enlarged bladder due to chronic retention. Hydronephrotic kidney may be palpable, but on rectal examination, there will be an enlarged prostate. It should be done when the bladder is empty. If not, you cannot feel the prostate. See, this is how, if you do a rectal examination, you will feel the posterior part of the prostate, for which your bladder has to be emptied. This is the symptom score, which is not necessary for you. So this is how you grade by PR examination. In grade 1, upper pole is easily reachable. In grade 2, upper pole is reachable with difficulty, and in grade 3, it cannot be reached. What are the investigations? Urine routine and microscopy and culture, blood urea, serum creatinine, serum electrolytes, ultrasound abdomen to look for any presence of residual urine, and urodynamics, that is the uroflowmetry. Urine flow rate, which is more than 50 mu seconds, is normal. 10 to 15 ml is equivocal, and which is less than 10 ml is low. Voiding pressure is also important, which is if it is more than if it is less than 60 centimeters of water is normal, 60 to 80 is equivocal, and more than 80 is high. You'll do a cystoscopy, then transrectal ultrasound. It is also useful to find out nodules if at all it is carcinomatous. Then acid phosphatase will be seen for prostate specific antigen, and then IBU. IBU is mainly done to see the kidney function. So how do you manage the patient? Patient with acute retention of urine, they require urethral catheterization, but you cannot force the catheter into the urethra. You have to be very gentle. If there is any resistance which is felt, then you have to do a suprapubic cystostomy. If the patient presents with uremia, then urethral catheterization is must. Conservative treatment, it is done in patients with relatively mild symptoms, that is reasonable flow rate is less than 10, and a good bladder emptying, that is residual urine should be more than 100 ml, sorry, less than 100 ml. Waiting for a period of 6 months can be done. Okay, so what are the drugs you will use? You will use alpha 1 adrenergic blocking agents such as prazosin. You can use selective alpha 1 adrenergic adenoreceptors blocking agents also, but remember prazosin. And then 5 alpha reductase inhibitor. What are the indications of surgery? That is prostatism, where you'll see frequency, dysuria, urgency. All these things should be present. Then if there is acute retention of urine, chronic retention of urine with residual volume more than 200 ml, and complications like hydroureter, hydronephrosis, stone formation, recurrent infections of the bladder, and hematuria. So what are all the surgeries? The prostate can be approached through different various ways. One is transurethral, retropubically, through the bladder, that is transvesical, phrased method, or through perineum. But we usually do transurethral resection of prostate, that is TURP. They can ask you a separate question as TURP. So you'll have to write the whole procedure for that. You have to write, if at all the question is TURP, then you better write the symptoms and signs, and then you have to write in which conditions you operate, and then give the and then you talk about TURP using sisters. So how do you do TURP? You use a cystoscope with fluid like glycine irrigation continuously. Enlarged prostate is identified and resected using a loop with a hand control. Resection is done using high frequency diathermy current. Remember this, high frequency diathermy current above the level of Vermonten. After surgery, continuous bladder irrigation using normal saline is done using three-way Foley's catheter. This is also important. You have to write this. And then antibiotics will be given. Catheter is removed within 72 hours of the surgery. What are the advantages of the TURP? There is no suprapubic incision done using resectoscope. Recurrence may occur in large prostate, but usually this will relieve the symptoms. TURP syndrome can develop they can ask you what is TURP syndrome. TURP syndrome is patient can develop is caused due to continuous postoperative irrigation using glycine solution. uh, there will be a faster recovery and early discharges possible. What is TURP syndrome? I'll talk to you about that later. What are the complications? Local complications are hemorrhage, infection, incontinence, perforation of the bladder or prostatic capsule, stricture urethra, retrograde ejaculation, and incompetence recurrence. So complications in general, that is TURP syndrome, that it is also called as water intoxication. What is TURP syndrome? The absorption of water into the circulation at the time of transurethral resection can give rise to congestive cardiac failures. During TURP, we do a continuous irrigation. So if there is any water overload, cardiac congestion can occur. So there will be cardiac failure, hyponatremia, and hemolysis. Accompanying this, there is a confusion and frequently confusion and other cerebral events, often mimicking a stroke. The incidence of this condition has been reduced since the introduction of isotonic glycine for performing the resection and the use of isotonic saline for postoperative irrigation also. So what will you do? You'll treat it with fluid restriction. And you can have cardiovascular symptoms such as pulmonary atelectasis, pneumonia, myocardial infarction, congestive cardiac failure, and deep venous thrombosis. What are the other methods you use to treat BPH? Transurethral incision of prostate, laser ablation, that is TUMT. What is laser ablation? Transurethral microwave therapy, transurethral needle ablation using high frequency radio waves, that is TUNA, high intensity US energy, ultrasonic energy, water induced thermotherapy, and then prostatic stents and balloon dilation. Thank you. Just stay online, your attendance will be taken.